Welcome to the podium, Dr. Aaron Katz, for Salvage Focal Therapy Post-Radiation discussion.
Good afternoon, everyone. It's a great pleasure to be here. Thanks to the moderators. I really appreciate it. I think I'm one of the oldest guys in the room, but I think for sure I'm one of the oldest guys that have done cryo for the longest time. My first case, when thinking about it, was August of 1994. At that time, I was just coming out of a fellowship at Columbia, and my old chairman, Dr. Carl Olson, said that we have this technology that's coming around. It has these large probes. It uses the liquid nitrogen gas, and you can try it, but only try it in patients who have prostate cancer that have had radiation-recurrent disease. There wasn't a warmer at that time. The ultrasound was in its early infancy. There was no thermocouple monitoring. And yet, I still felt that for a significant number of patients, it was able to extend their life and keep them off hormonal therapy, and published on my early results at that time. And then in 2004, one of the highlights of my career at the AUA was I was asked to debate Dr. Peter Scardino, who was chair at that time at Memorial, to debate salvage cryotherapy versus salvage radical prostatectomy. And I was, in my early career, I was extraordinarily nervous. I don't think I slept a wink the night before. But I prepared really hard and had great data. And the data really spoke for itself, that there really was no reason that patients, for the most part, should undergo a salvage radical prostatectomy because of their quality of life, and also there was no significant difference in their overall survival. So it's really exciting for me to be here now in 2024 with incredibly bright young people and minds that are going into the field to see all the new technologies that are coming around. And today I'm just going to talk briefly, and I only was given 10 minutes I don't have anything to disclose about my overall experience, and I don't know how many of you out there in the audience are considering to doing a salvage ablation. In my own practice, I do basically 3 types of cryotherapy. I either do a total gland, a partial gland, or a focal focal salvage. And when I say that I do a focal cryo, it really is a hemiablation, and I've always continued to do that, and I feel that at this point in time, with the technology that's available, I don't really just conform to the one area of the prostate for cancer, except for perhaps the patients that have anterior lesions. I think that you can certainly do a nice focal ablation in the anterior part of the gland. So this is what I know. This is my 30-year experience doing this. This is what I can tell you with that radiation recurrences do happen at our center on Long Island at NYU, where I run the program and the residency. We are very active in radiation therapy using stereotactic body radiotherapy, otherwise what we call, or what we have is a CyberKnife program. And overall, the patients do well, but I will tell you that we certainly do see a significant number of patients that have recurrence. They usually occur early. It can happen in the first 18 months, but it's rare. But I've seen patients that are out 18 months, and I've seen patients now out 10 years that have a slowly rising PSA and a recurrence. Usually, for the most part, it's the only sign is a PSA, and I am still remain old school and do a digital rectal examination. I think Art, there was discussion about Art doing it. I do DREs. You know, we don't have a stethoscope in urology. We don't have any tools, so the patients come in. I think that many of the guys, when they come in, they're expecting something. I have picked up many cancers. Actually, I've picked up a few rectal cancers, actually, with a DRE. So for the most part, patients are asymptomatic. And I think that with a slow rising PSA after radiotherapy, you've got to be really careful, and they can have aggressive cancer, and sometimes it's only by the DRE. So I think you need to be wise about PSA in the post-radiated patient, and if the patient's PSAs are rising, and if they're going up, if you want to use the Phoenix criteria, the Astro criteria, 3 rises in PSA, if you're concerned, I would definitely get an image, and I'll talk to you about the imaging modalities that I have found best. But again, most of these patients are asymptomatic. And when I'm discussing my options with these patients, what our realistic goals are for the patient, if they are otherwise healthy and young, and many of these patients that have undergone radiotherapy typically were not good candidates for radical prostatectomy because either they were older, they were not healthy, or they had clinical disease that you felt was extracapsular at the time. Maybe they had a PSA that was 30 and they had a Gleason 9 cancer, and you weren't going to treat them and cure them with radical prostatectomy alone, so they had high-dose radiation therapy and they had hormonal therapy as well. So I think when you're evaluating these patients, it's really critical to go back and look at their initial pathological stage and see if they were deemed curable at that time. The other goal that I think that has been clear in my mind is, many of the urologists in the country, when I've spoken to them, they see the PSAs are going up, the knee-jerk response is, well, we're going to put the patients on hormonal therapy. And so we all know about all the side effects that hormones can have for many of these patients. And so one of the goals, I think, would be, let's see if we can't delay the onset of ADT, maintain the quality of life as best we can, and of course, reduce anxiety. And I'm not saying that we should ever employ a therapy to reduce anxiety, but certainly there are many patients that come in that they're having their PSAs go up. They've been through a whole course of radiation. Maybe they had hormonal therapy, and now their PSAs are going up. So I think that we need to act, and I think this would clearly it has been very helpful for them. In terms of the AUA guidelines, salvage ablation using the current modalities such as cryoablation or HIFU are modalities that have been traditionally applied for whole gland treatment, although they may be used selectively for partial gland ablation or focal ablation, and cryoablation toxicity may correlate with the extent of the ablation. So obviously, if we're doing a much more extensive ablation, in my own experience, doing a total gland salvage ablation, these patients are going to have a longer catheter period of time. They are at higher risk, no doubt in my mind, of urinary incontinence, of prolonged retention, and possibly of rectal complications. Although I will say in my last several years, thankfully, knock on wood, I have not had the dreaded F word, fistula, in cryotherapy. There have been some studies looking at which patients are more likely to have a recurrence after SBRT, and not surprisingly here, it's going to be the patients that have that in the area where they had the PIRADS dominant 4 or 5 in the prostate. That's where you're going to have the likelihood of recurrence. And our good friend who's now with us at NYU, Michael Zalewski, had published this paper, and what he also found was that the patients that are going to fail are patients that are not getting the adequate dose. Interestingly, if you do just routine, not for cause, but just routine biopsies 2 years after radiotherapy, that these 2-year positive biopsies that are cancerous actually predate PSA failure in a significant number of patients, and the PSA level, which could be very low, in these patients that have positive biopsies and yet they haven't failed yet, they are more likely to have a continued biochemical recurrence compared to patients with a negative biopsy. Again, seems intuitive to us. So maybe we should be biopsying all of our patients much earlier, especially those patients that have been on a hormonal therapy and, you're saying, well, their PSAs look good. You want to get a testosterone level, make sure that testosterone levels have recovered. And here you see just a Kaplan-Meier curve of his paper showing again that the patients in red here that had a positive biopsy are much more likely to have a biochemical recurrence at the 5-year mark than those patients that had a negative biopsy. Again, intuitive. So this is kind of the algorithm that we've been following at our institution. Patients with a rising PSA, whether it be by PSA nadir, by the Phoenix, 2 points above, or by the Astro, whatever you're more comfortable with. I don't know what the right answer is there, but certainly if PSAs are rising, you want to get it early and you want to get your PSMA PET scan. This is, to me, this has really been a game changer. And if there is distant metastasis, then the patients go on either hormonal therapy with one of the new agents as well, either abiraterone, Xtandi, or darolutamide. But if there is local disease, and it was interesting in the discussion earlier, and I may be thinking about not getting an MRI. Do I need an MRI if the PET scan is showing that there's local disease there? Maybe I can rely on the PET scan alone, but I have to date just gotten an MRI to more localize where the disease is, and then do a fusion biopsy. Then if there's recurrent disease, and the patient hopefully will have unilateral disease on one side, and if sometimes you won't be given a Gleason score, but most of these patients, I will tell you, are being read as high risk disease. After the ablation, the patients typically have a catheter in for 5 days for the focal ablation. I do the procedures on Thursday. The catheter comes out on Monday, and it's extraordinarily rare for anybody to have a prolonged urinary retention. You do need a PSA. You want to get it at 3 months. If the PSA is more than a 50% reduction, which it should be in a focal ablation, then I continue with the PSA every 3 months. If they're not having a reduction in 50%, which they should, or their PSA is higher than their pre-op PSA, you may want to just repeat it in 6 weeks, and then again you have to repeat your imaging to see if they have a residual disease, or perhaps if the patients may have metastatic disease. And again, sometimes there's a delay in scheduling of when the patient had their PSMA PET biopsy and then their cryoablation, or their procedure. And these patients can have distant metastasis. So the options that we have here today that are potentially curative: radical surgery. I don't know if anyone in the room is doing it. Certainly robotics may have a play here. Cryotherapy, HIFU, and IRE. And the controllable, these are the 2 C words that I use with my patients. You either want to be controlled with cancer or cured with cancer. It's going to be ADT or observation. And this is we've seen this before many times in this conference, but clearly I think PET scan can show us. This is an example of a patient of ours that had a recurrent disease after radiotherapy, and you can see this patient has a high avid activity in the left anterior as well as in the right peripheral zone. And this is another patient of ours that had brachytherapy. You can see the seeds there, and again showing a significant disease there picked up on the PET scan. This is a patient, we follow these patients by PSA as well as MRI. I'd like to get an MRI at 1 year after the focal ablation, and you don't want to see any gadolinium uptake, and there's just a dense area there within the MRI. There's no evidence of any disease there. The patient did undergo a repeat biopsy with no cancer, and the majority of these patients will maintain their erections if they have reasonable erections to begin with. But again, many of these patients are older. They've had radiotherapy, so I think we have to be realistic. And what I tell my patients is that the majority of times, if you are potent beforehand, you're likely going to need some type of oral agent or possibly intracavernosal injection, even in a focal ablation. And again, it's managing expectations with our patients. These are the generation ice rods here that I've been using. And the procedure, again, takes me about an hour or so, sometimes actually less. A Foley catheter goes in, you do your ultrasound, you place your needles in thermocouples. We were talking before about the use of a warmer. I place a warmer in all these patients, especially even in the focal patients. To reduce incontinence, you can place an external sphincter temperature probe while you do your cystoscopy, and you want to make sure that it's sitting right there in the sphincter. And then it's a double freeze-thaw cycle, which I've always employed. Patients go to the recovery room and the patients go home, and it's done in an outpatient ambulatory center. This is my actual over the last few years. Since I've been at NYU, 144 focal cases. You see about splits, half are primary and half are salvage. This is the demographics of our salvage patients. Most of the patients are Caucasian, and the average age of the patients you see here is between 71 and 80, but we do see some patients that are in their 80s that can undergo this. Again, it does require general anesthesia, but there really hasn't been any fluid shifts. I've never, ever transfused a single patient, nor kept anyone overnight. 5-year overall progression-free survival looks pretty good at 73% with a good overall survival, and the cancer-specific survival in these series of patients is excellent, and there's about a 12% need of patients patients that are going to need additional hormonal therapy. Quality of life using this technology and this protocol, urinary tension is very low. Incontinence, I report, is less than 5%. The use of any pads at any time. I've not had any fistulas. There can be some penile pain, rare. And again, I think it was discussed earlier, you want to make sure that you put a thermocouple in the anterior part of the prostate so that you're not extending the ice up into the symphysis pubis, and some of those patients can develop penile numbness. We're entering our patients into the focal registry at Duke, and I encourage all of you to do that, to put it into the red cap, so we are continuing to do that. And this is just a slide showing some of the salvage focal cryotherapy outcomes that have been published in the literature. And you can see the median follow-up varies anywhere based from 18 months up to about 3 years, with biochemical disease-free survival rates looking really reasonably good in the majority of these studies. So I think overall, why patients should consider focal therapy: there is no hospital stay, there's no transfusions, there's really no long-term complications or secondary malignancies. It can be repeatable, although I will tell you that it's very rare in my experience that I have to repeat one, especially in the salvage setting. Low incontinence, minimal anesthesia, and a quick return to life. Once the catheter comes out, the patients are back to normal life. I think less is more for these patients, so if you can find patients in your practice that are good candidates for focal therapy, unilateral disease, I think that's great. Be smart, get early imaging and biopsy. Potency rates, if you're lucky, I think, but you have to be realistic with your patients. Very few incontinence, no fistulas, and gland size is key, but if you're doing a focal therapy, and again, most of these patients, their gland size is typically between 40 and 50 grams, so if you're doing a focal ablation, it really won't be much of a problem, and try to spare hormones if possible. Thank you very much for your time. Thank you.
Please stay up at the podium for a panel session. And we need Dr. Tan and Dr. Rothberg to the panel, please. Dr. Katz, we want you to speak again. I think while you're coming up to the podium, I'd like to make a comment that while at this meeting we've looked at efforts to move imaging to the forefront to avoid biopsy, we now are seeing interest in biopsy in the radiated patients. So I think we'd like to ask the panel a little bit about their understanding of the local control for modern series of radiation therapy and how a focal therapy may be combinational or additive. Dr. Katz, what do you think the local control for radiation therapy is?
The local control for radiation therapy? I mean, it's a very broad question. You'd have to look at the risk stratification of the individual patient. At our institution, most of the patients that are undergoing radiotherapy as a monotherapy without ADT are those patients with intermediate risk, grade group 2, grade group 3 disease. Although some of the patients with higher volume grade group 3 are using hormonal therapy, but we do have an active clinical trial right now at NYU randomizing patients to radiation versus radiation with ADT. I think that if you're asking me about patients as a monotherapy with radiation therapy for grade group 2 disease, it's excellent. I think the SBRT that we have here, I'm quoting patients around 95% disease-free control. It has been rather excellent. I just finished an interesting clinical trial with, it's called the Intrepid trial. We just finished accrual of about 240 patients, and NYU is one of the highest accruing centers, comparing radiation with Lupron, the standard Lupron and Casodex, versus radiation and darolutamide. And I've been super impressed with darolutamide and how great it is as a monotherapy. So we don't have all the results yet, but the early results look good. But even in those patients with grade group 3, I would say it's over 90%. Yeah.
Questions, please.
Yeah, if I could just comment on your question, Carrie, and then maybe ask Aaron a follow-up question. So one of the problems with local regional control assessment, of course, is that the definitions of control for radiation are quite self-fulfilling, right? The Phoenix criteria, et cetera, allows a delayed detection, and routinely we don't use imaging or biopsy to follow our radiation patients with favorable PSA kinetics or even unfavorable. So we're actually starting a project at NYU. Our radiation oncologists actually are interested in answering those questions. And so we're going to start biopsying all our radiation patients 2 years out. Now, it's interesting to note that the paper that Aaron quoted from Mike Zalewski, where it shows that the predominance of recurrence in SBRT patients is in the index lesion, they did biopsy all those men to figure that out. So I think that will start to answer some of those questions about the real recurrence rate is, and it probably enhances our ability to effectively salvage, because the corollary of not recognizing local regional recurrence is you can't do anything about it, right? So Aaron, the question I have for you though, notwithstanding that early detection, most patients are not early detected with salvage, at the time that they come to us for salvage. So how enthusiastic are you about focal? A lot of these people have disease in their SVs, a lot of them have periurethral disease, which might be affected by the warming catheter. So you have one of the richest experiences. Do you prefer focal, or do you think these men really need whole gland salvage?
I really like focal. I like focal for a number of reasons. And I think your question about the seminal vesicle invasion or disease outside will be answered with PSMA PET. I think the positive predictive value for the MRIs that we're using at NYU are terrific to pick up seminal vesicle invasion. So I was, in the earlier days when our MRIs were not as good, I was biopsying all patients, all the seminal vesicles. That was a routine. I would always do that. I've kind of gotten away with that because I'm relying on the MRI just being that good. But in patients that come back where the biopsy shows really higher grade disease, there are times where I'll go back and biopsy the seminal vesicles. But I think to your point about not getting patients in early enough and maybe they're not good candidates for salvage, it comes down to proper patient selection, right? And I think, if we as a urological community that are involved in patient care should be doing, as I think you're alluding to, earlier biopsies, irrespective of the PSA kinetics. I mean, I get a sense that that's what you're saying, right? In order for us to really drive home and to get that point to see, is there a biological recurrence or not? Even in the face of a PSA that's stable, these patients should undergo just routine biopsies at, let's say, a 2-point mark. Yeah, go ahead.
Yes. So actually, I have a question for Dr. Katz. When I was at Duke, we looked at the Duke data on salvage whole gland cryoablation for patients who failed radiation therapy. It was 110 patients or so. And we risk stratified them on their PSA after ablation, and essentially every patient with the PSA of above 0.5 will recur at some point in their life. This is for whole gland salvage cryoablation. Those patients with an undetectable PSA will have a 90% 5-year disease-free survival. This cutoff has been shown time and time again with 3 or 4 other papers out there in the literature showing that if your PSA is above 0.5, you will fail if you live long enough. So I wanted to get your thoughts on that, because if we go more focal and less whole gland, it is going to be very tough to determine the PSA value after ablation. And I do think it's important to know that. And perhaps we need to plan a randomized trial on whole gland versus focal ablation following radiation failure.
Yeah, I think that's a really interesting question. And I think like anything else, if you can get your PSA undetectable, like with radical prostatectomy and after a salvage ablation, your long-term prognosis is good. And I've always told that to patients with, with whole gland ablation. I think we need to do better as an organization, and hopefully the registry that you've had at Duke will help us to define the proper PSA cutoff after a focal ablation. Right now, I've been using less than 50%, that they more than 50% that the PSA should go down. But is that the right cutoff in the long term? I'm not so sure, and I think we do need more data. Yeah. Yeah.
Question.
Right. Hey, so this might be a little bit too provocative right now, but I know we're talking about starting to do biopsies earlier, but my patients are asking me, do I need a biopsy if I have a PSMA PET and an MRI that are positive? Yeah. So we may not be ready to go there yet, but I mean, what are any of your panel's thoughts on how close we are to potentially doing that?
Well, as one of the radiation oncologists, or maybe the only one here, I think we really need to establish it in the primary setting, whether it's focal therapy, radiation, as to the value of PSMA PET, because we're drinking from a fire hose of PSMA PET, no matter, I applaud the Australians for really leading the charge in the PSMA PET, but I think we really need to establish it as a biomarker, especially between the different agents, because there's going to be different thresholding, and I have radiology colleagues in the audience that will speak about this at the next session, even a little much more expertise than I do, but I think there's a lot more to investigate before we say we can avoid the biopsies in these patients.
Actually, the PSA kinetics sometimes need to be interpreted in a different way, similar to PSA velocity doubling times and rate of change over time. My concern is that biopsies post-radiation may be at the wrong time frame. Some data from years ago with inadequate radiation therapy still showed that at 1 year there was a 60% positive biopsy rate, but by year 3 it was down to about 10 to 15%. So you need to wait long enough after radiation to really believe the data. What's your opinion on that, Dr. Nagar?
Yeah, so the best data we have is what was, Dr. Katz cited in his studies, the 2-year biopsy rate, and we do have much older data in dose de-escalated, let's say, regimens, and where we don't have DARE or ARSI targeted therapy on top of the radiation. So right now, our sort of gold standard is the 2-year biopsy. That being said, with the trial data that will shortly be coming out with SBRT randomized in the PACE-B trial, showing what Dr. Katz showed as a 95% control rate at 5 years, I agree that ASTRO definition of nadir plus 2 is quite generous, so we need to start holding ourselves to a higher bar, as the urologists do with 0.2 as sort of the definition of biochemical failure, because Dr. Kishan and his group at UCLA showed men after SBRT that nadir below 0.2 had a longer distant metastasis-free survival. So I think the pendulum needs to start, we don't want to get too aggressive and start biopsying everyone, but at the same time, I think we need earlier readouts, especially on these trials, because in order to answer the next question, we need to figure out this question first.
I think there was a nice trial which showed that PSMA PET scan in the post-radiation setting is an outstanding investigation, even when Phoenix definition doesn't define it. So I think if we're going to do standard biopsies after radiotherapy in a trial, I think they have to be guided by a PSMA PET scan before you have your biopsy, because it's a bit like doing biopsies without an MRI. In the post-radiation setting, you can't do a biopsy without a PSMA, because, if it's in the seminal vesicle, it's in a tiny spot, you're probably going to miss it if you don't do the PSMA.
I feel like for some reason we hold ourselves to a much higher standard than the radiation oncologists. I'm glad that a lot of them are coming around to allow us to biopsy their patient. The history of the Phoenix criteria is actually very interesting. It's basically a meeting. They met up in Phoenix. They looked at 5 databases or 6, and they decided, all right, this is going to be our definition. There is really bad evidence pertaining to how they defined it. And, I do think we need to hold them accountable.